طيب اوكي، هل العدد 37 39 نقدر نبلش صح؟
بنقدر سيدي، العدد تقريبا اكتمل يعني تقريبا.
طيب اوكي تمام.
تمام سيدي.
تمام. طيب اوكي، هل العدد 37 39 نقدر نبلش صح؟
بنقدر سيدي، العدد تقريبا اكتمل يعني تقريبا. طيب سيدي، احنا الان اونلاين ان شاء الله. اذا بتسمح لي نعرف نفتتح المحاضرة بعد اذنك سيدي. الله يعطيكم العافية جميعا. شكرا لحضوركم جميعا. شكرا دكتور محمد على جهودك دائما في دعم محاضرات البرنامج العلمي. محاضرتنا اليوم ان شاء الله بعنوان سباين فراكتشرز مع دكتور محمد العليادات، اخصائي اول عمود فقري. راح يكون معنا ان شاء الله في محاضرتنا اليوم. دكتور محمد الله يعطيك العافية، تفضل سيدي.
الله يعافيك ناصر السلايدز موجودين عندك صح؟
بدك اعرض من عندي؟ بتصير ما في مشكلة.
اذا سمحت. يس.
طيب اعطيني بس دقيقة واحدة اذا هيك سيدي.
اوكي. معلش ناصر غلطتك.
لا ولا يهمك سيدي، بسيطة. بس اعمل لها شير من عندي بس دقيقة. طيب ما بعرف هيك السكرين واضحة عند الكل؟ واضحة عندكم؟
يس. كيف واضحة عندي؟
سيدي أهم شيء تكون واضحة عندك.
طيب اوكي
هيك عملنا. عم بقلب سلايدات، بتقلب سلايدات عند الشباب عند الجميع؟
يس تقلب فيهم. يس اوكي.
تمام اوكي تمام سيدي، جاهزين، تفضل سيدي.
Okay, so good evening everybody. كل عام وانتم بخير بمناسبة العيد المولد النبوي. Our lecture today is about thoracolumbar spine fracture. Nasser, can you go back just للslide اللي before إذا سمحت? Okay, and I gave this lecture last year. So yeah, this lecture will be for the new residents. And we start our lecture by this case. This is a 16-year-old female patient referred from a peripheral hospital in north of Jordan to our hospital. She has spine fracture, no spinal cord injury, no other associated injuries. Hello, we have this sagittal cut for the CT scan. We can see there's like L2, L1, and T12 fracture, mainly best fracture, or T9 compression fracture. According to this sagittal CT scan, I want everybody of you guys, to have a treatment option in his mind for this patient. According to the CT scan, just a CT scan. At the end of the lecture, we will discuss the treatment option for this patient and what we did for this patient. So spinal fractures that are a common musculoskeletal injuries. The annual incidence is estimated at 640 cases per 1 million individuals in North America. Most of these fractures happen at the thoracolumbar junctional area, mostly L1, T12. Why this area? Because it's a transitional zone between kyphotic rigid thoracic spine with mobile lordotic lumbar spine. If we want to classify these fractures anatomically, we have a pure thoracic from T1 to T9, thoracolumbar from T10 to L2, and lower lumbar from L3 to L5. Almost 30% of polytrauma patients, they have spine fractures because these fractures are high energy fractures. And in these patients, 20 to 25%, we have delayed diagnosis in spine fractures because most of these patients present with altered mental status, and the main focus and the emerge is on the abdomen or chest. We forget usually the spine. These spine fractures are associated with other injuries like hemothorax, pneumothorax, head injury, and long bone injuries. Before we start, we need to talk just a little bit about anatomy. We have the L5-S1 region. In general speaking, the last mobile disc, a big juicy disc, is at L5-S1, usually. Sometimes we have a normal variation at this area between L5 and S1. So, for example, between S1 and S2, we have a small disc, but sometimes we have like big juicy disc. So if we count the last mobile disc is between L5 and S1, then we have 6 lumbar vertebrae. And sometimes the disc between L5 and S1 is very small. And the large mobile disc is between L4 and L5. So if we count from caudal to cephalic, we will have 4 lumbar vertebrae, which we call it sacralization of the labrum, of the sacrum, sorry. So the most accurate method to count the vertebra to start cephalic to caudal, yani to start from C2, from the dense, instead of going from caudal to cephalic. So start C2, then go down. Next, please. And also we have PLC, posterior ligamentous complex. And from the name posterior, so it's located posteriorly at this area of the spine. Ligamentous consists of ligaments and complex multi-ligaments. The function of the PLC is to prevent overflexion and rotation and translation of the spine. So it's one of the strongest stabilizers of the spine. Consists of 4 parts: supraspinous ligaments above the supraspinous, interspinous ligaments, and facet joint capsule and ligamentum flavum. So if the PLC is injured, this means we have unstable spine. This means we need to fix the spine. PLC injury can be detected at MRI with Nelly stereo view as a high signal posteriorly, like this MRI. So in PLC, we will talk about PLC now in the classification. Next, please. Radiological finding of PLC injuries. If we have fracture dislocations, this means the PLC is injured. If we have increased intraspinous distance, this means highly suggested that the PLC is injured. Overkyphosis or hyperkyphosis, more than 30 degrees, there is a high suspicion that the PLC is injured. And when we have facet joint dislocations, also there is a high suspicion that the PLC is injured. So all these fractures are unstable fractures because of the PLC injury. So all these fractures need fixation. Next, please. The classification, we have 3 main classifications for the thoracolumbar spine fracture. We have Dennis classification, AO spine, and thoracolumbar injury classification and severity scale, CLICS. Next, please. So Dennis classification. Dennis is very popular, very common. Everybody uses this classification. But unfortunately, this classification is a historical classification. So just you find this classification in books and articles. Nobody uses it anymore to communicate, any between physicians. So it divides the spine to 3 columns: anterior column, middle column, posterior column. If the spinal fracture is, includes like 2 columns or the posterior, it's unstable. But it's, you have to know this classification, but don't use it because nobody uses it anymore. CLICS. CLICS is a very popular classification, and in Royal Medical Services we use it. This classification was published 2005 by Alexander Fagara. Consists of 3 parts. It's important to focus at this point. We have the morphology, integrity of the PLC, neurological status. As we said before, integrity of PLC depends on the MRI. So if intact, 0, suspected injury like 2 points, injury 3 points. If the total score, total points, is more than 4 points, this is a surgical case. If it's less than 4, it's 3, so non-surgical. If it's 4, it depends on the surgeons. Also, we have the morphology and the neurological status. Next, please.
تقدر تقرب شوي على الجهاز يكون الصوت أوضح شوي إذا ممكن.
سوري مش واضح الصوت.
هيك أوضح بس قرب.
طيب أوكي. أوكي. So morphology, we have compression fracture 1 point, burst fracture 2 points, translation, rotation, dislocation 3 points, and destruction 4 points. Now, just to make it clear, the difference between the compression with burst fracture. The compression usually involves one or single interplate, either superior interplate or the inferior interplate. Burst fractures, it might involve one interplate or two, or both interplates, the upper and lower. But in burst fractures, always the posterior wall is injured, and there is like potential for retrobulging of the posterior wall to the canal. In compression fracture, the posterior wall is intact. This is how we differentiate between compression and burst. And you can judge the integrity of the posterior wall using an axial CT scan. Distraction involvement the anterior posterior element without dislocation. Translation and rotation is dislocation of the spine. Next, please. So as we said, LICS, morphology, urological status, and PLC injury. If we have more than one injury, like more than one level injured, so usually we score the most severely affected level. And if we have dislocation L5 and we have compression fracture at T12, for example, we classify L5 because it's most injured. LICS provide us with a suggestion for the surgical treatment, the approach. If the PLC injury, this means you need to go posteriorly. If there is a neurological deficit with anterior compression, this means you go to anteriorly. Next, please. Low classification, as you see, this table is like complicated, so we'll try to make it easy. Just divide the spine to anterior element to posterior element. Vertebral body and the anterior element. Anything posterior to the vertebral body is posterior element. So A, compression fracture, is just in the anterior element. So the posterior element is intact. C, dislocation, involves both A and B, but we have dislocation. B, destruction, involves both anterior and posterior element. So again, compression, just anterior element. B, destruction, anterior and posterior. We see dislocation is anterior and posterior. Next. So L, compression, anterior. A0, minor fracture, spinous process fracture, transverse process fracture. Next. A1, wedge or wedge compression fracture. As we said, like single interplate, either superior or inferior. The posterior wall is intact. Next, please. A2, split fracture, the vertical split in the vertebral body. We call this fracture pincer fracture. The importance of this fracture, there is some elements of in painful non-union in the future, because the material of the disc. Sorry, Nasser, هذا incomplete نرجع قبليه على البنسر إذا سمحت. Okay, so the material of the disc could herniate to the vertebral body and leads to painful non-union fracture. Next, incomplete burst, as we said, single interplate, posterior wall is injured. A4, complete. Next, A4, complete burst fracture, both interplates with posterior wall is injured also. B, as we said, like anterior and posterior element. B, we have 3 types, easy to recall. Type 1, B1, the fracture lines go through bony element posteriorly and anteriorly. Go through the transverse process to the vertebral body. So it's a transosseous fracture. We call this chance fracture. B2 is osteoligamentous, so go through the ligaments to the vertebral body, through ligaments, then bone. B3 is hyperextension. Hyperextension mainly happens in ankylosing spondylitis or fusive spine. Next, please. C is fracture dislocation. Next. Next, please. Next. Next. I know the classification is very difficult, complicated, but we need to study this classification. So I'll leave this part for you to review it by yourself. Images. X-ray. X-ray is the radiograph, is the first line of investigation for spinal fracture. We have AP and lateral. AP, we might have decrease in the vertebral height, increase intrapedicular space, which mainly indicates best fracture, or coronal malalignment, which indicates subluxation or dislocation. Lateral view, we have decreased height, kyphosis, and also we can see the fracture of the spinous process. So we start with X-ray. Next, please. X-ray, if there is a kyphosis more than 30 degrees or loss of height more than 50 degrees, as we said before, there is a high suspicion that the PLC is injured. Next. Fine. Always we talk loss of height or post-traumatic kyphosis. We need to understand how we measure these degrees. And always we say vertebral body height loss, post-traumatic kyphosis. Also, post-traumatic kyphosis is very important when we treat patients conservatively. When you follow up the patient at the clinic, you need to measure this angle. If there is an increase in the kyphosis, this means that your patient is deteriorating, not responding. How we measure post-traumatic kyphosis? We have multiple measurements techniques. For example, this is the fracture one. We go to the interplate of the caudal vertebra, superior interplate of the cephalic, or the fracture vertebra, the interplate, superior interplate. So there are many techniques. Also for the vertebral height, either we take, for example, the anterior vertebral height divided by the posterior vertebral height, or we take the anterior vertebral height compared with other anterior vertebral height. Next. This study was published in the Eurospine, I think 2012. Around 300 expert spine surgeons were included in this study. The result was كالآتي. The most frequent used method to measure the kyphosis is the Cobb angle. You go to the fracture vertebra, one level above, to go to the superior interplate, superior of the superior vertebra to the fracture, and inferior interplate to the caudal vertebra. And this is the fracture one. فوقها واللي تحتها من جسم الكويس. So this is how we measure kyphosis, post-traumatic kyphosis. Also, the most universal accepted measurements technique to measure the vertebral height is to take the anterior vertebral height compared with the posterior vertebral height. And always we have this question: what if there is a decrease in the anterior vertebral height and the posterior? Both are decreased. So at this point, we compare the anterior with the anterior above, or with the anterior vertebral height with the vertebra below. So this is how we measure kyphosis. This is how we measure the height. Next. So we started with the X-ray, now CT scan. A CT scan is important. CT scan is for more finer details, mainly bony elements. And the importance of the CT scan, it's mandatory to differentiate between compression fracture or burst fracture. As we said before, because the classification is different between compression and burst fracture. For example, this lateral and AP view of L3, you cannot see any sign of posterior wall injury, just there is a compression single interplate. But after doing the CT scan, the axial CT scan, we can see here that the posterior wall is injured and the pieces are retrobulged to the canal. So now the classification changed from compression, which is 1 point, to burst, which is 2 points. Go back, please, Nasser. This study was published 2010 from San Diego Medical Center. They have found like 25% of burst fracture are misdiagnosed as compression fracture if just we use X-ray without CT scan. So CT scan again is mandatory in thoracolumbar spinal fracture. Next. Okay, and sometimes when a patient arrives to the emerge as a general surgery, the other teams working with him. So is visceral CT scan is enough? Yani, if they do, for example, thoracic, abdomen, or pelvis CT scan, is it enough, or do we need like to do spine CT scan? Many literatures, they have found that visceral CT scan, thoracic or abdominal or pelvis is thoracic or abdomen mainly is enough to clear the spine, the thoracolumbar spine. And if you are able to do reconstruction for these images, no need to do spine CT scan. So again, visceral CT scan is enough to clear the spine from the thoracolumbar spine. And if you are able to do reconstruction for these images, no need for whole spine CT scan. Next, please. MRI. MRI, is it important? No CT scan for bony element, MRI to assess mainly soft tissues. So to assess the spinal cord, paraspinal soft tissue, intervertebral disc, and PLC injured, as we said before. And also MRI is important to differentiate between pathological and traumatic fracture. The first MRI on the left, usually it's a pathological fracture. Why? Because the posterior wall is rounded and smooth. So this is a sign for pathological fracture. While traumatic to the right, the posterior wall is angulated. Also, if the pedicles are involved, this is mainly a pathological fracture. If we have paraspinal soft tissue involvement also, this is a pathological fracture. Next. How do we see fracture in MRI? T1, we see low signal, T2 high signal, and steer view, where the fat suppression view is we see it like bright signal. This is how we see fractures on MRI. Next, please. If your patient has respiratory distress, or he's hemodynamically unstable, or there's active bleeding wound, or his mental status is altered, don't rush for MRI. Don't send your patient to MRI. Also, you need to be careful if there is a cochlear implantation or vertebral artery aneurysm, or there is an open wound. You don't need to send your patient to the MRI. You need to wait. Next, please. Hello, we have this controversial topic. And no, if we have MRI, if we have a spine penetrating injury to the spine with retained metallic pieces, or if we have retained bullet fragments, is it contraindication to do MRI? Theoretically speaking, if we have a metallic piece in the body, this piece with MRI will dislodge and will act as a projectile subject, and it will injure other vital soft tissues. Sorry, بس الدس again, but go back, please. This is theoretically, but in literature, it's not mentioned at all in this thing has ever happened. Also for the bullet, it's contraindication. Domestic gunshots, usually the bullet is not ferromagnetic, يعني ما راح يسحب الجهاز, because the core of the bullet is mainly lead. So احنا بنهتم اكثر بالمريض اللي بيكون عنده bullet injury على lead toxicity. But this is not a clearance to do MRI for open wound or bullet injury spine fracture, it's preferable to do CT scan before you send your patient to the MRI. If the bullet, for example, in the bone, so you are not scared that this bullet will leave the vertebral body, as in this case, then you go for MRI. But for example, if the bullet is in the spinal canal, it's preferable, even there is like no cases has been documented, and this bullet will act as a projectile subject, but it's preferable, just to do CT scan and don't go for MRI. Next, please. But in thoracolumbar spine fracture, do we need MRI? Do we need CT scan? Is combined CT scan MRI is helpful? Why should we waste all these resources? How to make it clear? High energy thoracolumbar spine fracture. You need to CT scan your patients and you need to do MRI. MRI is mandatory. Why? Because with MRI, you can detect PLC injury. You can detect occult fractures. And also, many literatures, they have found that combined CT scan, MRI, and MRI after CT scan have changed the classification in 25% of the cases. And this thing leads to change the plan of treatment. And using MRI has changed the plan of treatment in 16% of the patients. So it's important to do MRI. Don't just like depend on CT scan. Next, please. This is it's not from our patients, but like it's in one of the literatures. CT scan shows like L1 burst fracture, T9 compression fracture, and T8 there was a suspicion of fracture. So after doing MRI, okay, we have L1 burst fracture, but then we have the PLC injury at the T9. So now we went from type A to type B classification, because now the posterior element is included. So this has changed the treatment option. Also, there is like a confusion in T8, which wasn't clear in CT scan. So MRI is mandatory in thoracolumbar spine fracture. You need to MRI your patient. Please don't refer any patients before MRI this patient, if there are no contraindications. Always we ask for steer view. Steer view, fast suppression view is the most sensitive way to detect spine, the most sensitive image to detect spine fracture and PLC injury. In this literature, I think 110 spine fractures were studied using steer view, and they have found like 41.8% of spinal injury. It was undetected or unsuspected or invisible in T2 and T1 MRI. So always ask for MRI, T1, T2, and sagittal steer. Next, please. The treatment options. The goal of treatment is stability, relieve pain, restore function, reduce deformity. In orthopedic in general, we have two options, either conservative or surgical fixation. In spine, conservative means orthosis. Next, please. Orthosis. We name orthosis according to the place of origin, for example, Milwaukee, Charleston, or the most universal accepted classification is according to the area of the spine that immobilized by this orthosis. The first one from the left, we call, because the cervical spine is included, so we call cervicothoracic orthosis. Second one, thoracolumbar sacral orthosis. Third one is like thoracolumbar sacral orthosis. So this is how we name the orthosis. Level of injury is very important. It's the critical point to choose the orthosis for treatment. Orthosis needs to immobilize the fractured part of the spine and above cephalic and caudal to that fractured part. If we have T7 fracture and proximal, cervical spine should be included. يعني ما بصير انه يكون عندك T5 T6 fracture, your patient is wearing lumbar sacral orthosis. The C spine should be included. هلا L5 fracture, the thigh should be included. We should have thigh cuff. Otherwise, you will increase the stress over the L5 and the fracture will deteriorate more kyphosis, more loss of vertebral height. From T8 to L4, TLSO. Next, please. Contraindications. If you have unstable fracture, this means your fracture needs surgery. No need for orthosis. Incomplete neurological deficit because it's an emergency for surgery. Polytrauma patient. And if you have a patient with tibia, femur fracture, spinal fracture, why do you need to put orthosis? Already he will spend like his time laying down in his bed. So if you apply orthosis, you will increase pressure ulcer over his back. He will be uncomfortable. So you don't need like for polytrauma patient to put orthosis. Morbid obese patients, because you won't be able like to stabilize the spine. Or if we have impaired skin sensation, or if we have skin disease, or impaired mental status. يعني مريض نايم بالاي سي يو ما في داعي للأورثوسيس. هلا احنا we are talking about orthosis. There is the belt. The belt is not for spine fracture. It's for low back pain. هلا sometimes we use the belt just to make the patient and other people aware that this patient has spine fracture. So to avoid some movement or to avoid like abnormal or sudden movement for the spine. But the belt by itself is not for a spine fracture. Next, please. Surgical fixation. The first reported case in history is for Dr. Hadra. He used silver wires for cervical spine fixation. I think this was 1891. Next. Surgical fixation, the spine has evolved over time. From the left, we have sublaminar wires, then we have hooks, then we have the pedicle screws. Pedicle screws started in France in the 60s. Just to make a few things clear, sublaminar wires and hooks, we still use it in some cases. For example, if you don't have like pedicles are very dysplastic. You are unable to insert a pedicle screws, you go for hooks or wires. But pedicle screws are superior to other instruments. Why? Mechanically more stable, fusion is better, you can correct deformity, you can reduce the spine with pedicle screws. And sometimes if the postural element is absent, for example, in the kind of previous, you are doing a revision surgery for a spine, and there is no postural elements, you cannot use the wires, but even if you don't have postural elements, you can use the pedicle screws. So worldwide, the pedicle screws are superior to all other instruments. Next, please. As I said, the fixation, either we do open or MIS. These two photos, go back please, are from our OR. So the left is the open. And the main difference between open and MIS, minimally invasive, is that in MIS, you do muscle splitting. You don't cut the muscle off, just splitting the muscle. While in the open, you cut the muscle, so you destroy the soft tissue. MIS, ناصر شوي لو سمحت. MIS is like less blood loss, less infection risk, less hospital stay, and the most important thing is like less post-operative pain, because you don't cut the muscles. While in the open, you destroy the soft tissue. There are indications for the open fixation, and there are indications for the MIS. For example, if you need to do reduction and decompression, you should go for open. If you have a spine dislocation, you cannot reduce it with MIS. Or some surgeons now, they argue they can do MIS fixation, then we'll go like for a minimally open decompression of the spine. But there are indications for each technique. Next, please. In general, in the spine, umbilical screws fixation, we talk about monosegment fixation, short segment, or long segment. We consider two vertebrae with intervertebral disc as a segment. So if we are fusing two vertebrae, this is monosegmental. Short segmental, we fix the vertebra above the fracture and the vertebra below. Long segment is two above and two below. And we have anterior and posterior approach. Next, please. Sorry, اتأخرت عليكم بس okay. طيب ضل معنا 20 minutes. Okay, so the treatment. Let's start with this spine dislocation. The easiest thing. You cannot treat fracture dislocation, dislocated spine with conservative treatment. You need to go for surgery because it's unstable. The PLC is usually injured, and you go for posterior long segmented instrumented diffusion. So one indication for long segment is spine fracture dislocation. Next, please. For example, this is one of our patients presented with L2 spine fracture dislocation, and we went posteriorly with long segment fixation and diffusion. We reduced the fracture with decompression, and we realigned the spine. Next, please. And the distraction injury, type B, involving the anterior posterior element. Usually, these fractures present with separation of bony or ligamentous structures. This leads to functional spinal destruction, unstable. So type B is unstable also, needs surgical fixation. So either we go long segment fixation or short segment fixation, or monosegment for type B. Next, please. Distraction, hyperextension, and closing long segment fixation. So now we have two indications for long segment fixation: fracture dislocation or hyperextension. Next, please. هذا P2 اللي حكينا osteoligamentous، إنه في إن PLC is injured والbony is injured. P2, either you go for short segment fixation and you fuse the vertebra above or vertebra below and the fracture vertebra, or just like two vertebrae. If the superior end plate is injured, so we instrument the fracture vertebra with a vertebra above. Next, please. For example, this is one of our patients, L2, P2 fracture, PLC is injured. Pes fracture, as we can see. So PLC injured is like 3 points, pes fracture 2 points, so this is 5, this is surgical. So we went for short segment fixation. Next, please. And P1 اللي حكينا ligamentous, transosseous fracture, اللي هو through the bony parts of the posterior element to bony parts of the anterior element. As this one, the fracture went from the spinous process to the vertebral body. We call chance fracture. So either we go for short segment or monosegment. Next, please. For example, this is L2 chance fracture. You can see the fracture here in the spinous process. And we went for short segment fracture. Instrumentation, sorry. Next, please. In the past, they used to treat chance fracture with extension brace. High quality literatures, they have found in the post-traumatic kyphosis, pain with functional outcome, as well as with when you treat chance fracture conservatively. So now the guidelines is to treat this fracture surgically. هلا عشان بس نوضح نقطة، احنا حكينا المونوسيجمنت انه the fracture vertebra with the vertebra above or the vertebra below, short segment above and below. هلا mechanically, there is no difference in terms of mechanical stability between monosegment and short segment. The same stability. But most surgeons, they think if you add more screws, you add more stability, which is not true. So B1 and B2 fracture, you can go for monosegment fixation, unless there are like some other points you need to take in consideration. If it's a junctional area, we will not go deep at this point. Next, please. هلا compression fracture. Compression fracture حكينا involvement of one in the plate, either the superior or inferior, and the posterior wall is intact. So it's just anterior element. So if the PLC is intact, no neurological deficit, conservative treatment for compression fracture. Do we need to brace fractures cranial to T11, and from T11 to T1 to T2? Do we need to put brace? Usually, these fractures have more stability than other fractures because of the rib cage adds stability to the spine. And there is like mixed evidence about using or not using bracing. But most surgeons, they prefer to brace patients with compression fracture from 6 to 12 weeks. Although the evidence is there's no difference between bracing and non-bracing compression fracture in the outcome. And my advice for our patients, we brace them. Unless we have a highly educated patient who can understand all the instructions and the outcome, then we don't brace him. Next, please. A big controversy in this treatment of burst fracture. Let's divide this subject to two types, surgical and non-surgical. Burst fracture with PLC injury, surgical treatment. MRI, C review showed PLC injury, surgical treatment. Burst fracture with a neurological deficit, surgical treatment. If it's partial, it's an emergency. And there is a term called stable burst fracture. Stable burst fracture if the loss of the height less than 20% or the kyphosis less than 20%. This is non-surgical treatment. هلا عشان باش نكون واضحين النقاط هاي هو مختلفة من كتب السباين وأنا بعرف تقرأوا من orthopedic. There is a difference between the numbers. But I think you should تعتمد الموضوع orthopedic. So stable burst fracture, it's either single interplate or double interplate with the posterior wall in the loss of height less than 20% or kyphosis 20%, conservative treatment, non-surgical treatment. Next, please. The guidelines for stable burst fracture is non-surgical treatment. Worldwide, most spine surgeons, they prefer to fix burst fracture against the guidelines. When we are part of this community. So for example, this is L1 burst fracture. PLC is not injured. According to LEX is 2, but because it's burst fracture, we went and we did monosegment fixation. Although we could treat this patient non-surgically. Even it's a thoracolumbar junctional area, but he was a young patient. Next, please. Stable burst fracture, loss of height less than 20%, kyphosis less than 20 degrees. Is bracing effective? This study, it made a hit with spine surgery, published 2013. There was no difference between or no superiority for bracing over non-bracing for burst fracture. And even the burst fracture, you can just ask the patient, to continue his life without bracing. Not to continue to do all these things, you need to give him instructions. You can give him some medication, activity modification, that's it. No need for bracing if it's stable fracture. But again, in our practice, no, we brace them. Although against guidelines, but you need to brace them. And I'd just like to summarize things. Signs of instability that need surgical fixation. We have fracture dislocation, type C, or type B. We said B1, B2, B3, or sternal fracture. Because usually, if you have a sternal fracture, this means you have a high energy fracture. This means the PLC is injured and you have unstable spine. Or if we have loss of height more than 50% with kyphosis more than 30 degrees. This is, I told you before, these numbers are different between the orthoped and the spine. And we consider 20 and 20. We don't loss of height more than 50% to 30%, no, 20, 20. So all these are signs of instability that need surgical fixation. Next, please. And let's go back to our patient that we started the lecture with. As we said, 60 years old female patient, falling down, isolated spinal fractures, multiple levels fractures, non-surgical deficit. Next, please. So CT scan showed L2, L1, T12 base fracture. The posterior was involved. Next, please. And T8 compression fracture. Sorry, T9 compression fracture. So now, after doing MRI, صوت واضح؟ Okay. هلا after doing the MRI at the lumbar spine, there was no PLC injury. So all these fractures are base fracture. So according to LEX type 2, neurological deficit 0, PLC is not injured, so 0, so this is 2. So these lumbar fractures go with conservative treatment. But the surprise was, go back ناصر شوي إذا سمحت. And after doing MRI, I apologize for the quality of the image, but at T9, the PLC was injured. So this means, according to LEX, like 3 points for the PLC injury and 1 point for the compression fracture. So it was a compression fracture with PLC injury. So the total score is 4 points. Now the surgeon decides to go with conservative or surgical. But because PLC is injured, so we decided to go for surgical fixation for this case. Next, please. So we fused, so the T9 was fractured. So we went T8, T9, and T10. And we treated the lumbar fractures conservatively. So without MRI, we won't be able to detect the PLC injury. For this reason, MRI is important. And as you can see, it changed the classification and changed the method of the treatment in our practice. Oh, I think we're done. شكرا كثير، يعطيك العافية.
الله يعافيك سيدي، شكرا جزيلا على جهودك، يعطيك العافية.
أنا أسف.
دكتور محمد الله يعطيك العافية على هالمحاضرة القيمة، الله يعطيك العافية.
الله يعافيك.
شباب أي أسئلة دكتور محمد؟
مرحبا سيدي، يعطيك العافية.
أهلا وسهلا.
الله يسلمك، مند العرموط.
أهلا مولانا.
يا سيدي سؤال هسه، في عندي سؤالين. الأول، المرضى اللي بيجونا مثلا بيكون عنده تروما وبنعمل له سيتي سكان وما بيبين مثلا في عنده فراكشر أو شيء، تمام؟ وبكون يشتكي مثلا من بين أو يعني في خلينا نحكي inability to walk أو severe pain in the back. Is it an indication إنه نعمل له MRI؟ يعني هاي الشغلة الأولى، بيجونا المرضى على الطوارئ. الشغلة الثانية، في طفلة دخلت قبل فترة وكان في عندها تشخصت إنه سكاي ورا injury, spinal cord injury without radiological abnormality.
نعم صحيح.
هلا سيدي الفكرة إنه بهذول المرضى surgery is an indication، خلينا نحكي للإيري مثلا إذا كان في ligamentous injury أو إذا كان مثلا إحنا we couldn't assess إنه نعمل CT scan، أوكي أمورهم تمام، ما في fracture، ما في dislocation، مش عاملين compression على السباينال كورد، ما في sign of BCL injury، وبنفس الوقت في neurological deficit. يعني كان ممكن السيرجري an option for this patient أو لا؟
هلا أوكي. هلا number one. الله يعافيك. أوكي thank you. هلا number one. If there's a high energy trauma، يعني مريضك حادث سيارة واقع عن طابق ثاني وبيشكي من low back pain, you need to MRI him. If it's a high energy trauma, it's important. هلا if it's minor trauma, he's just complaining of localized pain or diffuse pain, يعني mildly localized, you cannot localize the pain, diffuse back pain. هلا this patient, you can give him an appointment to clinic. You don't need to MRI him in emergency room. But if it's high energy trauma, localized tenderness, no, you need to MRI him. حتى لو كان polytrauma patients. هلا as long as he has no neurological deficit, he is a polytrauma patient, he's not moving, you can postpone MRI for the next day. يعني polytrauma patients, abdomen, extremities, you don't need to rush for MRI right now. If he has neurological deficit, neurologically intact, we can move the limbs, sphincters doing okay, you don't need to MRI him, you can wait, no rush. هلا السؤال الثاني انه unfortunately انه this is terms just the pediatric injury. هلا if you couldn't locate the area of spinal cord injury, you cannot operate on these patients unless there is a sign يعني for the place of the spinal cord compression. هلا usually spinal cord injury it's not a compression in this subject of spinal cord injury. It's other other pathophysiology way for this injury. So if you don't have radiological indications where the site of the spinal cord injury, you cannot operate.
تمام سيدي، الله يعطيك العافيه.
يعطيك العافيه دكتور محمد.
هلا اهلا.
محمد عبد الله انا سيدي.
سيدي
سؤال الكوكسيال فراكتشر ايش التريتمنت تبعتها بيكون؟
الكوكسيجل فراكتشر
بالضبط
ولا الساكل فراكتشر؟
هلا هي سيدي يعني لا هي بالضبط يعني الكيس مرت عليه وشفتها في الكوكس كان. نعم.
هلا usually first of all you need to differentiate this is abnormal variation or it's a fracture. So again we go back to the MRI steric view. If there is a high signal, this is a fracture. Most coccygeal fracture we treat it conservatively with pain management. Do not silicone thing they use it to sit on. And then we go after that. If there is like a chronic coccydynia, we go for injection. The surgical indication is excision. It's not correction, but it's very limited. The reasons for our causes, our justification for surgical correction. You need to wait at least 3 months in your patient. So you need to try first conservative treatment. Failure of conservative treatment, then you need to make sure the source of the pain is the fracture itself. تعمل injections, you see if the pain disappear. Then after that, you go for surgical treatment. So the surgical treatment for coccygeal fracture is the last option we use with our patients. And most patients, they continue to have pain after surgical resection of that part of the coccyx. The area is like very dirty, so the complication is very high. We have a very high rate complication at that area. So go always with conservative treatment till the patient present with intractable severe pain after failure of or conservative treatment. Then we go for surgical resection of that part.
شكرا سيدي، يسلم.
دكتور محمد الله يعطيك العافيه.
الله يعافيك.
سؤال بالنسبه posterior ligamentous complex في جريد. هلا انت ورجيتنا صوره لمريضه وعندها compression fracture وبين بالام ار اي انه في عندها PLC injury.
Yes.
هلا for you as a surgeon treating these cases are you convinced انه مثلا PLC injury انتم بتعملوها معامله all or none? Either there is a signal indicating injury or there is no signal. This is how you interpret the MR usually.
First of all, this patient بالتحديد احنا اخذنا صوره انترا اوب والبي ال سي كانت injured. according to Lex you have 3 degrees. Either you have no injury which is 0 or you have a suspicion. You have a signal but that signal is not clear, or you have a very bright white signal. Then so you have sometimes you suspect a PLC injury, but you are not sure till you open and you see, And to be honest with you, in many cases, not a few cases, there was a suspicion, but after we opened, the PLC was intact or mildly injured, not completely injured.
Yes.
So it depends على surgeon experience himself, يعني على experience of the surgeon.
But you don't have any grading system لهم هذول.
No. Either no or suspicion or there is.
Thank you. في سؤال تاني بس regarding اللي هو احنا دائما بنوصل بالسباين بنحكي كثير عن موضوع المانجمنت initially والinitial management classification, but once we reach اللي هو surgical aspect, يعني مثلا biomechanics of the fixation itself, how the spine will heal, how يعني خلينا نحكي عن orthopedic surgeon قاعد بكلينيك ممكن يجي مريض يعرف انه this is poor fixation, this is a good fixation, this is adequate inadequate. يعني for us احنا دائما eager انه احنا هيك شوي to explore more موضوع يعني ال fixation itself والbiomechanics وهي الشغلات, و even the exposures basically how we يعني expose و reach that area that we want to reach. فهاي ممكن تكون بصراحة يعني هيك كمان شغلة إضافة جميلة للمحاضرة اللي أعطتنا إياها, يعني يكون في عنا إشي أكتر عشان نفسنا إحنا لما نكون نتعامل مع صور, أنت عارف يعني basically what we need to see rods وسكروز مثلا, صح؟ هلا إحنا لما نكون برا الفيلد كسباين يعني كسباين سيرجنز, بس بيهمنا مرات بالجنرال براكتس بيجيك مريض عنده كومبلينت معينة تفهم على الأقلية إنه this is adequate inadequate, this is healing not healing. ببساطة ليش إحنا حطينا هذا الإشي, ليش ثبتنا فوق, ليش ثبتنا تحت. I think يعني راح تكون موضوع مفيد حتى للجميع إنه شوية to understand more mechanics of fixation of the spine.
دكتور مثلا I agree with you يعني سيدي إنه كلامك 100%, especially إنه إحنا بس يعني عيادتنا موجودة بالمدينة, فالزملاء بالperipheral hospitals يعني they see our patients sometimes, they do follow up for our patients. I agree with you, and I'm happy to prepare another lecture for هنحكي إنه مثلا how to deal with the spine patients in the emergency room, ونعمل other section of the lecture is the instrumentation of the spine, you know, how to read the X-rays, or how to deal with the patients after surgical fixation or surgical treatment. يعني I'm happy to prepare this lecture.
Thank you very much. Thank you. شكرا على المحاضرة. تسلم دكتور محمد, الله يسعدك.
أي سؤال الشباب؟ دكتور سليمان الشراد موجود معانا صح؟
معانا سيدي موجود دكتور سليمان.
الله يعطيك العافية
أي سؤال؟
معلمي دكتور محمد, الله يعطيك العافية.
لا حبيب الشعب, عندك أي سؤال, أي استفسار؟
لا بالعكس سيدي, محاضرة قيمة وجميل, حتى أنا كسباين فيلو يعني كثير استفدت منها, فالله يعطيك العافية, ويكون إن شاء الله يكون الشباب استفادوا من المعلومات القيمة اللي أعطيتها, ويعطيك العافية سيدي.
الله يعطيك. دكتور عمر بشماف موجود معنا لسه صح؟ عمر موجود؟
عمر شفت خلال المحاضرة بس بجوز إنه
عمر يعني هي سينيور سباين سيرجن معنا, إذا بحب أضيف أي شيء على المحاضرة أو he wants to correct يعني any information I mentioned يعني بس شكله طلع. طيب شباب, ضل حدا في عنده أي سؤال, أي استفسار؟
أي دكتور عمر معنا سيدي.
مساء الخير, الله يعطيك العافية دكتور محمد. أنا سوري كنت عم بسوق فاتح المحاضرة وعم بسمع بلوتوث. لا توقفت. بصراحة المعلومات كلها كويسة وإن شاء الله الشباب كلهم يستفيدوا, ما في شيء أضيف.
بس تخالف عمر 50 هسه. طيب أوكي, شكرا عمر, شكرا
جزيلا, شكرا.
طيب ناصر, أظن خلصنا, ما ظل في أسئلة. شكرا للجميع, شكرا لكم جميعا. وإذا حدا عنده أي استفسار أو فكر باستفسار بيقدر يبعث لي, يحكي معي تليفون whatever, بنشوفه بالمدينة. يعني اللي بشوف أي واحد من الشباب الزملاء عنده أي استفسار أو أي سؤال, later on he wants to contact me على الرحب والسعة, أو يعني أي حدا من التيم, دكتور سليمان, دكتور سامي, دكتور عمر بشماف, دكتور رائد, anyone.
يعطيك العافية سيدي.
يعطيكم العافية جميعا, شكرا.
هذا رائع سيدي, يعطيك العافية. دكتور مثنى يعطيك العافية سيدي, جهودكم الدائمة.
احنا شاكرين دكتور مثنى حضور المحاضرة صراحة.
أكيد سيدي طبعا, دكتور مثنى متواصل لدعم برنامج العلمي. طيب شكرا لحضور الجميع, نلتقيكم إن شاء الله الأسبوع القادم.
شكرا.
هسه الآن راح ننهي هذا الميتنج, وراح أبعث لكم إن شاء الله شباب لينك ثاني على مجموعة اللجنة العلمية عشان نبدأ الموك إكزام للتروما سكشن اللي مرت معنا خلال الشهر الماضي. يعطيكم العافيه جميعا.